Acute lower abdominal pain in a woman may have several causes. These include pelvic inflammatory disease, ruptured ectopic pregnancy, and septic abortion. And the latter two are surgical emergencies which require extreme urgency in their management. So PID is caused by organisms which may be sexually transmitted, infection related, or other bacteria that are sent from the lower genital tract and produce inflammation of the uterus, fallopian tubes, and other structures in the pelvis. However, after excluding ectopic pregnancy, STI related organisms are the most likely cause of lower abdominal pain in a sexually active woman who has not recently delivered a baby or has no past or recent history of uterine instrumentation. The presence of intrauterine contraceptive devices um, favors the development of PID, particularly in the month following insertion. So the causes are ectopic pregnancy, appendicitis, ovarian torsion, STI related, non-STI related, for example, urinary tract infections, septic abortion, postpartum sepsis, and foreign body, including IUCD. But the symptoms are fever, low abdominal pain, pain with sexual intercourse as dyspareunia, offensive vaginal discharge, dysuria, or urethral discomfort. The signs that are usually elicited are abnormal vaginal discharge, tenderness or moving the cervix, cervical excitation or bimanual vaginal examination, low abdominal tenderness, adnexal tenderness, and adnexal masses. Investigations are pelvic ultrasound, pregnancy tests if sexually active, and amenorrhea present, also high vaginal swab, culture and sensitivity. The main treatment objectives are to identify and manage potential life-threatening cases, for example, ectopic, and also to treat any underlying bacterial infection, to relieve pain and inflammation. And pharmacological treatment, that's where surgery is indicated. Removal of IUCD if present 3 days after initiation of drug therapy. Pharmacological treatment for pelvic inflammatory disease, that's mild cases. First line treatment, to give ciprofloxacin oral 500 milligrams 12 hourly for 3 days, and doxycycline oral 10 milligrams 12 hourly for 14 days, and metronidazole oral 400 milligrams 12 hourly for 14 days. They consider hospitalization or referral in the following cases, as well as surgical emergencies like ectopic pregnancies, appendicitis cannot be excluded. And patient is pregnant, as PID is uncommon in pregnancy, especially after the first trimester. And although if the patient does not respond clinically to oral antimicrobial therapy, when the patient is unable to follow or tolerate an outpatient oral regimen, the patient has severe illness associated with nausea and vomiting or high fever, and the patient has a tubovarian abscess, HIV infection, youth or adolescents, particularly if compliance is an issue. Also, for pelvic inflammatory disease, in severe cases, give ceftriaxone IM 250 milligrams daily for 3 days, and doxycycline oral 100 milligrams 12 hourly for 3 days, and then metronidazole IV 500 milligrams 8 hourly for 3 days, and then doxycycline oral 100 milligrams 12 hourly for 14 days, and metronidazole oral 400 milligrams 12 hourly for 14 days. The use of ciprofloxacin and doxycycline is contraindicated in pregnancy and lactating women. Also, for pain relief, give diclofenac rectal oral OIM 52 100 milligrams 8 to 12 hourly with a maximum dosage of 100 milligrams twice daily, or mefenamic acid oral 500 milligrams 8 hourly. So referral criteria: refer to a gynecologist or a general surgeon if there is no improvement or if a pelvic abscess is suspected. So flow charts. Let's quickly look at it. So female patient complains of low abdominal pain. You take history and examine. In any of the following present: if missed or overdue period, recent delivery or miscarriage or abortion, there's abdominal guarding and rebound tenderness or rebound tenderness, abdominal mass, abnormal vaginal bleeding. If these are true, you assess low abdominal tenderness and vaginal discharge, cervical excitation tenderness. If no, you educate to counsel, you promote and provide condoms, with offer counseling and testing as CT, and then follow up if pain persists beyond 3 days. If yes, that's for low abdominal tenderness and vaginal discharge, cervical excitation tenderness. If yes, the patient is unable to it's as if the patient is unable to follow or tolerate an outpatient oral regimen, has severe illness associated with nausea and vomiting or high fever, has a tube ovarian abscess, or youth or adolescents, particularly if compliance is an issue. If no, you treat for PID as outpatient regimen, and educate or counsel, promote, provide condoms, partner management. You offer counseling and testing. Follow up after 3 days or sooner if pain persists, and if improved, you continue treatment. If no, you refer to the hospital. Also, if any of the following are present: as missed or overdue period, recent delivery, miscarriage or abortion, abdominal guarding and rebound tenderness, abdominal mass, and abnormal vaginal bleeding, refer to the hospital. As also, if PID, inpatient protocol, you treat appropriately, educate and counsel, promote and provide condoms to you, and partner management to is recommended. You offer counseling and testing, and for other courses you advise appropriately.